Right, now on the same neuroeffector operators, we will discuss sympathomimetic drugs, the drugs which increase the sympathetic activity. You know, there are two ways to increase the sympathetic activity. Number one is some drugs go directly to the receptors on the post-synaptic surface or on the effector tissue, and drugs directly stimulate the receptors. If a group of drug is directly stimulating the receptors, right, we call them direct sympathomimetic drugs. Sympathomimetic drugs, okay, let's classify them here. Sympathomimetic drugs. As a broad category, these drugs produce the pharmacological actions which mimic to the physiological actions of sympathetic nervous system, right? Now, these sympathomimetic drugs are direct acting and indirectly acting, direct acting and indirectly acting sympathomimetic drugs, right? Direct acting means the drugs which directly stimulate the adrenergic receptors. Drugs which directly stimulate the adrenergic receptors. These are adrenergic receptors agonist. And indirectly acting sympathomimetic drugs are those drugs which act on the nerve ending, sympathetic nerve ending, right, and alter the function of the sympathetic nerve ending, right, in such a way that amount of norepinephrine released by the nerve ending is more, or amount of norepinephrine present in synaptic area is more than normal. I will explain what are these drugs and how do they work. So what are indirectly sympathomimetic drugs? Indirectly sympathomimetic drugs do not work directly on the receptor, on the postsynaptic surface. They work on sympathetic nerve ending and alter some function here to keep or release more norepinephrine or neurotransmitter in the synaptic cleft. And of course, when there is more neurotransmitter here, it will act on the receptor in a more intensity. So such drugs are called indirectly acting drugs. You want to learn about directly acting drugs first or indirectly acting? Direct action first. That is easy, right? Directly acting drugs are which will stimulate these receptors directly. For example, there is alpha 1 stimulant drug, alpha 1 and agonist, or there are alpha 1 and alpha 2 agonist. There are some drugs which are alpha 1 stimulant, beta 1 stimulant and beta 2 stimulant. Then there are drugs which are beta 1 and beta 2 stimulant. There are drugs which are mainly beta 2 stimulant. There are some drugs which will mainly stimulate alpha 1 receptor. There are some drugs which will stimulate alpha 1 and alpha 2. Okay, rather we should put here little bit change. Look here. Drugs which mainly stimulate only alpha 1 receptor, drugs which mainly stimulate only alpha 2 receptors, and drugs which stimulate alpha 1 receptor, beta 1 receptor and beta 2 receptors, drugs which stimulate mainly beta 1 and beta 2, and there are drugs which stimulate mainly beta 1 and drugs which stimulate mainly beta 2. How many categories? 1, 2, 3, 4, 5 and 6 categories. Is that right? Let's move step by step. First of all, the drug which will stimulate alpha 1. Okay, I will remove this area and compare and contrast them. The drugs which stimulate only alpha 1 receptor. Yeah, mainly alpha 1 receptor. They bind with the alpha 1 receptor and stimulate here. Right, who will tell me the name of such drugs? Phenylephrine. Have you heard of phenylephrine? So phenylephrine is the drug, is mainly alpha-1 stimulant. Is that right? Phenylephrine. Then we go to the next drug, which mainly stimulate alpha-2. This is alpha-1 stimulant. Now we come to drug which alpha-2 stimulant. Now it is very interesting to look at it, that if there is a drug which is alpha-2 stimulant, it will stimulate here. It has stimulatory action on alpha-2. You know what will happen? It is sympathomimetic or sympatholytic. Use your own head. If a drug is stimulating here, it means it is giving the message to the nerve ending. There is a lot of neurotransmitter here. Nerve ending will be inhibited and release of neurotransmitter will be less. So this is an unusual exception, that a drug which act on presynaptic alpha-2 receptors and stimulate them too much, it is giving message to the nerve ending. There is a lot of norepinephrine here, and actually norepinephrine release will be less and it will become sympatholytic. This is a very tricky situation. Are you understanding me? Anyone who could not understand? Right? So drugs which stimulate alpha-2 receptors, basically they inhibit the neurotransmitter release. This is an unusual situation. But if there is a drug which block this, right? It is a blocker. If drug can block alpha-2 receptors, it means nerve ending is releasing the neurotransmitter, but it is itself blind, it is totally blind to the amount of neurotransmitter present here. Because when this receptor is blocked, whatever norepinephrine is released, can it stimulate this receptor? No. When this receptor is not stimulated, nerve ending receive the message that probably there is no neurotransmitter there. So nerve ending will start releasing more neurotransmitter. Are you understanding? So it's a very unusual situation when you talk about the alpha-2 receptor stimulant and blocker, right? Alpha-2 receptor on presynaptic nerve ending are the eyes of the nerve ending, by which they look at the amount of neurotransmitter at the synaptic cleft. This is synaptic cleft neurotransmitter sensor for the auto inhibition. When you have a drug which stimulate alpha-2 receptors, right, then nerve ending stop releasing the neurotransmitter. But if you have a drug which inhibits the alpha-2 receptors, nerve ending will no more inhibited and it will release excessive amount of norepinephrine. Now, can you tell me some drug which can stimulate alpha-2 receptors? Please tell me. A drug which can stimulate alpha-2 receptor and nerve ending will be too much inhibited and it will not release neurotransmitter. The drug is, you know it, I can bet it you know it. Drug is clonidine. Have you heard of clonidine? Clonidine in central nervous system at vasomotor center in medulla. It binds with alpha-2 receptors and stimulates them. It stimulates them, and nerve ending the fooled. They think they have released too much norepinephrine. They stop releasing the norepinephrine. So vasomotor center is inhibited. When vasomotor center is inhibited, then from medulla down going sympathetic flow and vasomotor sympathetic outflow all is inhibited, and blood vessels dilate and blood pressure goes down. So such drugs which are alpha-2 stimulant are antihypertensive, like clonidine. Clonidine. Okay, here I am saying alpha-2 stimulant, that is clonidine. But remember, this is not sympathomimetic. This is an unusual central sympatholytic. Central mean in the central nervous system. Sympatholytic. Clonidine. This is unusual situation. The receptor is stimulated but it inhibits the nerve ending, and release of norepinephrine become less, and vasomotor system is inhibited, and blood pressure goes down. Is that right? There are two important central antihypertensive drugs. One is clonidine, right, which stimulate alpha-2 receptors, inhibit the nerve ending of sympathetic nerve ending of noradrenergic system in vasomotor center. Vasomotor center is inhibited. Other centrally acting antihypertensive drug is alpha-methyl dopa. That also work on the vasomotor center, but in a different way. Alpha-methyl dopa, as I told you, will be taken up by the system and released as pseudo neurotransmitter, and again neurotransmission fails. So clonidine reduces the discharge of normal norepinephrine from the nerve ending, but alpha-methyl dopa lead to the release of pseudo neurotransmitter and reduce synthesis of original neurotransmitter. Am I clear? So alpha-1 stimulant is sympathomimetic, but alpha-2 stimulant is sympatholytic. This is very unusual point. Then we come to a drug which can stimulate alpha-1, also stimulate, okay, I will talk about beta-1, but very little action on beta-2. What is this drug? It has now not, first drug was having action only on alpha-1, phenylephrine. Now we have a drug which has alpha-1 action and beta-1 action, but not beta-2. What is the drug? Please tell me, norepinephrine, which we are studying from last 2 hours. The very speciality of norepinephrine is it stimulates alpha-1 and beta-1, but does not stimulate beta-2 significantly. Right? Norepinephrine. Am I clear really? Okay, go one more step. Come to another drug which will stimulate alpha-1, beta-1, and now we have a drug which also stimulates beta-2. Right? Alpha-1, beta-1 and beta-2, all of them are stimulated. What is the name of this drug? Yes, ma'am. Excellent. It is epinephrine. So, my dear students, the real difference in norepinephrine and epinephrine is norepinephrine has alpha-1, beta-1 action, but less beta-2. Epinephrine is really balanced. It stimulates alpha-1, beta-1 and beta-2, all of them. If you really know receptor distribution in the body, by this simple thing you can tell the action of the drug. Of course, norepinephrine does not have beta-2 actions, and epinephrine does have. For example, beta-2 action is bronchodilation. Norepinephrine will not do bronchodilation, epinephrine will. Beta-2 action on the liver is glycogenolysis. Right? So this will not do glycogenolysis, but epinephrine will do glycogenolysis, and we'll talk these things later. Let's move forward. Now, funny thing, another drug which does not have alpha-1 action but has mainly beta-1 and beta-2 action. Look at it. We started the drugs with main alpha-1 action, full alpha-1 action. Then we came to drug which has alpha-1 and beta-1 action. Then we came to the drug which has alpha-1, beta-1 and beta-2 action. Now we are reducing the action of alpha-1. We are left with which actions? Mainly beta-1 and beta-2. What's the name of the drug? Which is mainly stimulating beta-1 and beta-2. I'm about to be impressed by that lady. Okay, this young man. Excellent. Isoproterenol. Very good. Isoproterenol. You know, it's so easy now. If you know the beta-1, beta-2 action in the body, these are the actions of isoproterenol. But if you add alpha-1 action to this, you get epinephrine. And if you have alpha-1, beta-1 action and reduce the action of beta-2, you have action of norepinephrine. Is it difficult? I don't know why it is so easy. Okay, now we come to a little more thing. We come to drug which is mainly beta-1 action, and then of course drug which is mainly beta-2 action. Actually, we have a drug which has, in a very high doses, supraphysiological doses, there is a neurotransmitter or hormone which has beta-1 action. But if dose become very high, then it start alpha-1 action also. It has little alpha-1 action, but in very high doses it will start alpha 1 action. Yeah, and it has dopamine receptor action also. There's a drug which stimulates dopamine receptors. It can also stimulate beta 1 receptors, and in very high concentration can stimulate alpha 1 action. What is the name of the drug? Dopamine. Very good. Dopamine. So dopamine can stimulate beta 1 receptors in the heart and increase cardiac output. And dopamine at the same time can act on dopamine receptor on renal vessels and dilate them. Let me tell you this tricky thing. Listen. If a patient comes to you who is undergoing severe reduction in cardiac failure, very less cardiac failure, and due to reduced cardiac failure, there is so little, blood flow to the kidney that you are about to have acute tubular necrosis. When there is severe ischemia to the kidney, you are going to have acute tubular necrosis, renal shutdown. So if you have a patient with cardiac failure and associated risk of what? Renal shutdown due to reduced renal blood flow, you have to do two things. You have to stimulate the heart and you have to dilate the renal vessels simultaneously. And we have a double action drug which has beta 1 action on the heart and dopamine receptor stimulation on the renal vessel, and you will increase the cardiac output, and that drug will be renoprotective as well, protect the kidney from acute tubular necrosis. The drug is dopamine. That is why in very severe shocks, when cardiac output is down, we give infusion of dopamine, that it should stimulate the cardiac output and keep the renal vessels dilated. Is that right? But you have to be very careful. Every good thing does not remain good under all circumstances. If unfortunately you give excessive dose of dopamine at very high concentration, it starts stimulating alpha 1 receptor. And when alpha 1 receptors are stimulated in the renal vessel, they will again shut down. So what happens? You have to give moderate doses and take very good care that infusion rate is well controlled. You will study when I will teach you dopamine, that dopamine has very good dopamine receptor stimulation at 2 microgram. I should not go into detail of that right now. Just trust me. At very low doses, dopamine stimulate what? Dopamine receptors and dilate the renal vessels. In moderate doses, beta 1 action start and also become cardio stimulant. At very high doses, unfortunately start stimulating alpha 1 receptors, and that may lead to again renal vessel constriction. Is that right? Any question up to this? No? But if you have another patient who has no problem of renal vasoconstriction, only cardiac output is down. If you want to give a drug to a person to stimulate his heart, you want to stimulate his heart, increase cardiac output, but you don't want renal dilation, you don't want renal dilation, because there is not so much shock that person is going into acute tubular necrosis, then dopamine is not the drug of choice. You want a drug which mainly work only on beta 1 receptor. You want a drug which mainly work on, okay, I will put it here, drug which mainly work on beta 1 stimulant and not stimulating the dopamine receptor. What is the name of the drug? Again listen, there are two patients with reduced cardiac output. In one patient, you need to stimulate the heart and dilate the renal vessels to protect the kidney from acute tubular necrosis. The choice of drug is dopamine. Another patient, he has reduced cardiac output, you want to keep the heart a little bit stimulated, but there is no problem with the kidney. Such patients are classically like heart transplant patient. When heart is transplanted, you give some support stimulant to the heart so that in new environment it keep on working. Is that right? Very good. Dr. Rose has told us this drug is dobutamine. We'll study all these things in detail, but right now you only remember that dopamine is cardiostimulant and renal vessel dilator, but dobutamine is mainly cardiostimulant. Am I clear? There's no problem? And then we come to a very important group of drugs which are mainly beta 2 stimulant? Yes, who will tell me? Drugs which are beta 2 stimulant. Yes, salbutamol, albuterol, ritodrine. These are very commonly used for, especially salbutamol, albuterol. All these drugs are used as bronchodilators. Right, so I put it here, salbutamol. So all of these drugs are sympathomimetic because they increase some of the function of sympathetic nervous system in the body, right? But because all of these drugs are working on the receptors, so we can call them directly acting sympathomimetic drug. Only one exception was alpha-2 stimulant, which was indirectly acting sympatholytic. In this whole story, right, remember, clonidine was not sympathomimetic, it is sympatholytic, even though it stimulates the adrenergic receptor. Am I really clear? Anyone who is confused, raise your hand. No one is confused. Okay. Now we come to the drugs which really work on presynaptic nerve ending and increase the sympathetic action. Right? For that purpose, first of all, I will tell you a drug, right, which works here on this reuptake mechanism. And this drug, which what it is doing? This drug is, what this drug is doing? It is blocking the reuptake mechanism. Now what will happen? You are yourself intelligent, that can it go in? No, so it will be staying here. A drug which bind with reuptake 1 mechanism, right, and whatever neurotransmitter is released, the recapture of or reuptake of neurotransmitter is reduced, so neurotransmitter stays here longer in higher concentration and it really works more. So what we have done? We have got stimulation of the receptors indirectly. So we call it indirect sympathomimetic drug. Can you tell me the name of this drug? Yeah. Okay, remove the tail and put the name. What's the name of this drug? Pardon? Of course, he's so intelligent, he tells me it is reuptake inhibitors. He's right, these are reuptake inhibitors. I want the name of the drug. Yeah. Hurt toxins, I think this is something all of you must know. Have you heard of something called cocaine? Of course, it's drug, but illicit drug. What cocaine does? When you take cocaine, you become hyperstimulated. You must be knowing Gavin, right? So, don't laugh at him. He never told me, right? So what happens when you take cocaine? Cocaine goes and bind with the sympathetic nerve endings and block the reuptake. So whatever normal amount of norepinephrine is released, it stays there and stimulates in central nervous system because cocaine is lipid soluble, goes into central nervous system, right? And sympathetic drive is more, and you feel hyper stimulated and excited. Some people like situations like this, right? But cocaine does it with very strong cocaine. But there are some drugs also we use. I mean, there are drugs, they also bind it with very and slow down this reuptake. They little bit block this reuptake mechanism, but little bit, so that concentration of norepinephrine remains in this area little bit high, right? Those drugs bind with these reuptake mechanism at dopaminergic neurons, at noradrenergic neurons, at adrenergic neurons. So multiple neurotransmitters in central nervous system, their concentration is increased in synapses. What is the group of that drug called? Yeah? No. All of you know that. All of you know that. Have you heard of tricyclic antidepressants? This is what tricyclic antidepressants are doing. Tricyclic antidepressants. Tricyclic antidepressants. What they are doing? They bind with reuptake 1, but not as strongly as cocaine because they are not cocaines. Right? They bind it mildly. and they slightly reduce the reuptake, and they keep on increasing the concentration of these excitatory neuron in the central nervous system synapses so that you come out of depression. Is that right? We'll talk their actions in detail when I teach you tricyclic antidepressants. Of course, there will be time for that also one day. Any question up to this? And I think it's very important to tell at this stage. Have you heard of the drug Prozac? SSRIs. What is that SSRIs? SSRIs. Yes. Selective serotonin reuptake inhibitors. Classical example is Prozac. What Prozac is doing? I think, what is the active drug in the Prozac? No, that is paroxetine is related with that. Fluoxetine. What is the drug in Prozac? Fluoxetine. Okay. Yeah, Paxil has paroxetine and fluoxetine. So fluoxetine or paroxetine or related drug, they are also reuptake inhibitors, but they selectively block reuptake mechanisms only on serotonergic neurons. So that is why they are given selective serotonin reuptake inhibitors, because tricyclic antidepressants are non-selective. They inhibit the reuptake of epinephrine, they inhibit the reuptake of norepinephrine, they inhibit the reuptake of dopamine. Am I clear? So, tricyclic antidepressant act on the reuptake mechanisms in central nervous system and don't allow the released neurotransmitter to be reuptaken. Concentration of adrenergic neurotransmitters and synaptic area become more, and there's more action on the adrenergic receptors. Am I clear? Right? And there's another way to increase the release. You know how? Okay, let me tell you. You block this cat, Mao, right? You put a drug, right? And this is like a basket, and this is trapped. And now when norepinephrine is coming back, can it be destroyed by this? So it will be accumulated here and effectively reuptaken into vesicle. So all the norepinephrine which is coming, normally a part of it is destroyed by Mao and part of it is stored again into vesicle. But if drug blocks monoamine oxidase system, then whatever is reuptaken, if of course this drug is not there, whatever is reuptaken, right, that will be, all of it will be stored there, and neurotransmitters stored in the vesicles will be very high. So with every action potential, extra amount of the drug neurotransmitter is released, and it becomes a sort of sympathomimetic action to mild degree. What is the drug here? Yeah, these are also antidepressant drugs because they increase neurotransmitter concentration here. Yeah, who is going to tell me what is the drug here? Anyone? This drug is number one, Pargail. I don't know from where they find this name. Pargailin. Pargylin. How you read it? Pargailin. Pargailin. And other drug is prenylcypromine. Prenylcypromine. These are also monoamine oxidase inhibitors, and they are also used as antidepressants. Again, we'll discuss into detail when I will teach you antidepressants. Right? So one way to increase neurotransmitter here is don't allow the reuptake. Other is allow the reuptake but don't allow intraneuronal destruction. So everything will be stored over there. Right? And the last group of the drugs which facilitate binding of vesicle with this membrane. So they increase the release of neurotransmitters. There is another group of drug which can enter into the sympathetic nerve endings and help and accelerate the fusion of vesicles with the nerve membrane and release neurotransmitter more efficiently, right? So what is this drug now? Now I think you must answer. There are drugs which go into central nervous system, bind with sympathetic nerve endings, or we can say adrenergic and noradrenergic and dopaminergic nerve endings, and lead to excessive release of these neurotransmitter. Name of the drug is, which will stimulate you a little bit. Yes, you know it. Your all friends may be taking it near the exams. Amphetamines. You never heard of it? Amphetamines. Right? These are amphetamines. Amphetamines. Right? These are also increasing the release of adrenergic neurotransmitters in central nervous system. And also with amphetamine, the other drug is tyramine. Tyramine. Please don't confuse tyramine with tyrosine. And don't confuse tyramine with alpha-methyl tyrosine. Right? Alpha-methyl tyrosine inhibit the tyrosine hydroxylase and reduces sympathetic activity. But tyramine helps the vesicle to fuse more efficiently with the membrane and increase sympathetic activity. That's all for today. Do you have any question? No question?
Let me ask, what part is the labetalol in us? Is it?
You are talking about labetalol. That is a very unusual drug. That is alpha blocker as well as beta blocker. We'll talk about it when we'll discuss into detail sympatholytic drugs. It was just a very brief introduction to put some basic concepts in your mind. We'll talk about labetalol, that is alpha blocker as well as beta 1 blocker. Plus labetalol has one more action we'll discuss. It activates the potassium channels, let the potassium leak out of the myocardial cell and reduce their resting membrane potential. We'll talk about these things later.
Yeah, one other question.
Right? Any more? Class dismissed.